All right, let's jump right in. Today, we're doing a deep dive into a really critical, life-saving procedure that you'll see in pretty much any ER or ICU. It's called a tube thoracostomy, but you probably know it as a chest tube insertion.
So, have you ever wondered what happens when a lung collapses, or when air or fluid builds up in the chest, creating a genuine life-or-death emergency? How do doctors relieve that pressure right there on the spot? Well, that is exactly what this procedure is for, and we're going to break down exactly how it's done.
Okay, so let's get into the why. Putting in a chest tube isn't just some routine thing. It is a critical, time-sensitive response to incredibly dangerous conditions. We're talking about a serious buildup of pressure inside the chest that can stop someone from breathing and can even stop the heart itself.
At the end of the day, it really all boils down to two main problems. You either need to get unwanted air out, or you need to drain dangerous fluid. So on the left, you've got things like a pneumothorax, that's a collapsed lung, where air is getting trapped and building up pressure. And on the right, it's all about draining fluid, like blood from an injury, a hemothorax, or maybe even infected pus. Two different problems, one very elegant solution.
But here's the thing. Before anyone makes a single move, it is all about preparation. Success here really hinges on meticulous planning and having every single tool you need right at your fingertips. Because when you're working this close to the lungs and heart, precision is absolutely everything. So let's look at the anatomical map clinicians use. And the whole plan, the entire procedure, starts with this one fundamental rule: find the safe triangle. Now, this isn't just a suggestion, it's a very specific anatomical landmark. Think of it like a safe corridor that ensures the tube avoids all the major blood vessels, nerves, and organs.
So what exactly is this safe triangle? Well, it's defined by some very clear boundaries. You got the edge of the pec major muscle at the front, the latissimus dorsum muscle at the back, a line right above the nipple that forms the base, and the very top of it is right up in the armpit. Doctors literally map this out on the patient's body to find that perfect, safe entry point.
And here it is. This is the golden rule of insertion. Once you're in that safe triangle, you have to follow this command. Why? It's simple. Tucked just underneath every single rib is a bundle of nerves, arteries, and veins. If you hit that bundle, you can cause serious bleeding or chronic pain. So going above the rib isn't just a good idea, it is absolutely non-negotiable.
So with the location mapped out, you need the tool kit ready to go. We're talking sterile everything, of course. A local anesthetic like lidocaine to numb the area really well. A scalpel for that first incision. A curved clamp that's used for dissecting. Sutures to secure the tube. And of course, the drainage system itself, which, by the way, gets connected before insertion so you don't accidentally let air back into the chest.
All right, we've found our map, we've got our tools ready. Let's walk through the procedure itself. This is not about speed. It's about a very deliberate, very focused sequence of critical actions, where every single step matters.
First, you position the patient with their arm up and out of the way to really open up that safe triangle. The site is confirmed, often with an ultrasound. Then comes a generous amount of anesthetic. You have to numb the skin, the muscle, and especially the pleura, which is the super sensitive lining around the lung. Next, a small skin incision is made. And then, and this is key, you do a blunt dissection. Instead of just piercing through, a clamp is used to gently spread the muscle layers apart, creating a tunnel down to the pleura.
Now, before that tube goes anywhere, the clinician performs this absolutely crucial safety check, the finger sweep. A gloved finger is actually inserted into the tract that was just created. And this one simple move does three vital things. 1, it confirms you're actually inside the chest. 2, it clears away any scar tissue. And 3, it protects the internal organs from getting injured when the tube goes in. It is an indispensable safety pause.
Okay, the path is clear. Now the tube can be advanced, and its direction is totally intentional. For air, it's aimed up towards the top of the lung because, air rises. For fluid, it's guided down and towards the back because that's where fluid pools with gravity. Once it's in, it is sutured firmly to the skin so it can't move, and then you immediately check to make sure it's working.
But look, the job isn't over just because the tube is secured. The aftermath, all the careful checks, knowing the risks, and the rules for managing the patient is just as important. These are what we call the ICU pearls, where great care really makes all the difference.
So, how do you know it actually worked? Well, there are two ways, and you check them right away.
First, a chest X-ray is the gold standard. It lets you visually confirm the tube's exact position. But even before that, right at the bedside, you're looking at the drainage system. If you can see the fluid level inside swinging up and down as the patient breathes, or see bubbling as air escapes the chest, that's your instant confirmation that it's in the right spot and doing its job.
You know, this is an invasive procedure, so it definitely isn't without risks, which is exactly why every one of those safety steps is so critical. Complications can include anything from bleeding from that intercostal artery we talked about, to injuring the lung or diaphragm, or even introducing an infection. There's even a rare complication where the lung can get flooded with fluid if it reinflates too quickly.
And speaking of risks, this number is one every single clinician has burned into their memory: 1,500 milliliters. If more than 1.5 liters of blood gushes out right after you put the tube in, that signals a massive hemorrhage. That is not a wait-and-see situation. That is an immediate, lights and sirens call to a surgeon.
So, let's finish up with some of those ICU pearls. This is bedside gold for managing these patients. First, the vast majority of complications happen because the tube was put in the wrong place, which just reinforces how important that safe triangle is. Second, if nothing is draining out, you have to suspect the tube is in the wrong position. Here's a huge safety tip. Never, ever clamp a chest tube during transport if it was placed for a collapsed lung. You could trap air and cause the whole emergency all over again. And finally, never underestimate good pain control. It really helps patients breathe more deeply and recover faster.
So, if you take away absolutely nothing else from this, remember this one sentence. The entire safety mantra of this procedure can be boiled down to these few words: above the rib, inside the safe triangle, blunt dissection, finger first. That right there is the core sequence that saves lives. It's just a perfect example of how a really complex medical action is guided by simple, clear, and absolutely critical rules.